Hi, my name is Cassandra Mohr. I'm a medical student from UT Houston, and I'll be presenting the review of SAGE's Gerd guidelines and recommendations. Thank you for the opportunity to present. The authors have no disclosures. The SAGE's Guidelines Committee developed evidence-based guidelines for the management of patients with Gerd, published in 2010 and recently updated. The aim of this study is to assess the guidelines lacking agreement amongst experts or lacking support from randomized controlled trials. Several SAGE's guidelines lack agreement amongst experts. One is the use of mesh reinforcement for decreasing the incidence of wrap herniation. Another area of disagreement is the benefits of robotic assistance compared to laparoscopic assistance. Additionally, the impact of age on outcomes of fundoplication surgery lacks expert certainty. The use of an intraoperative bougie has also not reached a consensus. There are various SAGE's guidelines lacking support from randomized controlled trials. One guideline in this category explores the impact of anti-reflex surgery on dysphagia symptoms. Another guideline lacking data at low risk for bias compares the post-operative outcomes of obese to non-obese patients. A multi-center retrospective review was conducted on all patients who underwent fundoplication surgery from June 2015 to March 2020 at one of 4 institutions. Our primary outcome for mesh versus suture and obese versus non-obese patients was hernia recurrence. Our primary outcome for both robotic versus laparoscopic and age over 65 versus less than 65 was dendoclavian outcomes. Our primary outcome for bougie versus no bougie was post-operative dysphagia. We conducted a multivariable regression analysis with variables chosen ahead of time, including age, gender, BMI, and prior surgery. A total of 444 patients were included. Many of our patients were white, female, and obese, with an ASA status of 2 or 3. Of the patients that underwent a preoperative EGD, around 50% had a Hill grade 2 through 4 hiatal hernia identified. All patients reported reflex symptoms prior to undergoing surgery, often along with regurgitation, dysphagia, and pain. Patients had a median follow-up of 16 months. On regression analysis, there was no significant difference in occurrence of wrap herniation for a mesh versus suture reinforcement. Robotic and laparoscopic assistance had similar short-term outcomes, measured by dendoclavian complications. Patients over 65 years old did not have significant differences in occurrence of dendoclavian complications compared to patients less than 65. Usage of intraoperative bougie did not result in significantly lower rates of postoperative dysphagia. And lastly, obese patients did not have significantly higher incidence of wrap herniation. Of the 444 patients, 178 reported preoperative dysphagia and 266 did not. Both of these groups had similar rates of postoperative dysphagia, with almost 84% of patients that endorsed preoperative dysphagia reporting resolution of symptoms at last clinic visit. This multi-center review of Gerd treatment supported many of the SAGE's guidelines, including robotic assistance is more expensive with similar short-term outcomes to laparoscopic assistance. Following laparoscopic anti-reflex surgery, dysphagia has been reported to significantly improve from preoperative values, and outcomes in older patients are similar to outcomes of younger patients undergoing anti-reflex surgery. Guidelines that were not supported were the long-term effectiveness of fundoplication in obese individuals has been questioned due to higher failure rates, a bougie has been found to be effective, and mesh reinforcement may be beneficial in decreasing the incidence of wrap herniation. So in conclusion, our study augments the smaller randomized controlled trials, but further studies at low risk for bias are needed to further refine these guidelines. And these are my references. Thank you.